Good afternoon, everyone. This is really an incredible opportunity to talk about mental health as it relates to TB. So to begin with, we are often told that TB is a medical problem treated only within clinical frameworks. But this perspective almost always ignores all the emotional and psychological challenges that people endure at each stage of the illness. And in truth, TB shapes how you value your health and life, how you work, how you define your self-worth, how you cope, and where you ultimately place your trust in people and systems, and how you make decisions about your care. And this makes TB and mental health inextricably linked. So recently, there have been initiatives to integrate mental health services into TB care. But despite this, the TB ecosystem, meaning the health systems, providers, organizations, donors, still tend to reach back to clinical frameworks. And in these cases, mental health screening tools are applied primarily to identify patients with major depressive or anxiety disorders as per clinical definitions. And these definitions are usually looked upon from the lens of the ability to function in daily life and work. And the question we really want to ask ourselves is functionality the only measure we want to use in describing psychological distress? And this is not to say that it isn't an important step forward, but it also limits the definition of mental health. And it'll only estimate that about 10% of the TB population requires any type of mental health support, and 2 to 3% require any type of specialized support. And we know this not to be the case. Part of the challenge could also be that we haven't provided the vocabulary, or even if we haven't institutionalized the vocabulary to describe the nature of a mental health challenge. And we can't measure what we can't describe, and we can't hold systems accountable for what we can't measure. And I'll give two brief examples from various patient illness narratives that describe the nature of a mental health challenge. The first was described as a transfer of apathy. This is where individuals narrated this experience as being, they're initially concerned about their symptoms and deteriorating health, but they did seek care across multiple providers, but they were met with apathy by external health systems. And this apathy was subsequently just internalized by the patient over time, and where they slowly began to devalue their own health and care and stopped engaging with treatment or making positive care-seeking decisions. Another example is when individuals experience this feeling that they deserve to be ill because of some actions they've done in their life. And this is often reinforced by various religious and cultural frameworks. But this type of a mental health framework is deeply harmful for both the patient's psychological and physical care. And again, this type of psychological distress causes patients to devalue their own health and life and stop engaging with treatment or any positive care-seeking decisions. So locating and addressing these types of mental health challenges is really critical, and integrating mental health support with TB care has to be treated with urgency, and it has to become synonymous with TB care because it really affects everything downstream, and not only clinical parameters, but overall quality of life. And in respect to holding systems accountable, we will need to develop a vocabulary of metrics and metrics that matter to patients with respect to their mental health. And if we can institutionalize these metrics within the National TB Program with the same rigor we've used to institutionalize clinical metrics around medication adherence or monitoring of clinical outcomes, we can really hold the entire TB system accountable for making mental health a priority. And I really look forward to new insights and discussions on how to take this forward. Thank you.